Kidney stone is a highly prevalent disease, and 1 in 10 Americans are affected by it.
There's a lot of passage of stones we just don't know about, and it's the tip of the iceberg when you see the symptomatic stone. There's a lot going on.
We did not see a signal for kidney stones as a risk factor for chronic kidney disease.
Welcome to another episode of the ASN Kidney Translation Podcast. I'm your host, Dr. Matthew Sparks from Duke University. On this episode, we will review articles from the ASN portfolio of journals that discuss recent advances in kidney stones. First, from JASN, we'll explore a Mendelian randomization study examining the bidirectional relationship between kidney stones and chronic kidney disease. Next, from Kidney 360, we'll break down how pharmacotherapy and stone mineral subtype influence long-term recurrence rates in calcium stone formers. And finally, a CJASN study investigates the risk factors for asymptomatic kidney stone passage in adults with recurrent stones from the No Stone trial. Stay tuned as we unpack these important findings, bringing you fresh insights on how they could impact patient care and the future of nephrology. Let's get started. I'm joined by Dr. John Lesky from the Mayo Clinic in Rochester, Minnesota. We'll discuss a recent paper in JASN titled Association Between Kidney Stones and CKD, a bidirectional Mendelian randomization study. Welcome to ASN Kidney Translation.
Thank you. I'm really glad to be here and talk about our recent paper.
Well, I have to say, first, when you read the title, you're not sure what you're going to find, but this sort of goes in a different direction than what we're traditionally taught about the association between CKD and kidney stones, both in potential causality and also the association of having stones with CKD. The other thing is it has very unique methods, which is this Mendelian randomization. So I guess before we get started, can you sort of set the stage for how this entire project started?
Sure. So we've been working in more genetics databases in general. And one of the focuses of our group here has been on the genetics of kidney stone disease. And really, I would say that there's exploding amounts of data available now for doing this kind of work. So as over the last 5 years, a lot of these big cohorts where they have pretty dense genotyping data available, and then it's also linked to some amount of clinical data with those given individuals. And it just has really opened up the ability to do these sort of epidemiological and association type analyses. And so this was kind of a natural progression from what we're doing with our own local cohorts here and trying to branch out into what's available worldwide, really.
And what was known about the link between kidney stones and CKD prior to this paper?
This is something that we started working on over 10 years ago, for sure, with Andrew Rule here. So just doing traditional sort of epidemiological type studies and looking at chronic kidney disease as an exposure, I should say kidney stones as an exposure, and chronic kidney disease as the outcome, and then trying to control for all the things that might be confounding that, like diabetes and high blood pressure. And we had found that doing those sort of things as carefully as one could do here in Olmsted County was the main studies that we did, that indeed it looked like kidney stones was a risk factor for chronic kidney disease, defined in different ways, either by elevation in your serum creatinine over some period of time, or actually the incidence of kidney failure requiring kidney replacement therapy, or higher amounts of albumin in the urine. So all of those things seem to be associated. If you had kidney stones, you were high risk for those. And then others have done that in other sorts of observational databases as well. So this is something that's, I would say, been published in multiple places over the last 10, 15 years for sure.
Had there been any study that questioned that dogma prior to this?
I don't think so. And I think if you think about it just in general, kidney, we know certain patients with kidney stones get kidney failure. If you have big kidney stones, need a lot of surgeries, certainly that can cause some kidney damage, or some of the rare genetic causes like primary hyperoxaluria, those people do get kidney failure. So certainly some people with kidney stones are going to get kidney failure for sure. And so I think that there was a certain amount of, I don't know, face validity to this, that people would assume that this probably was a true association.
What you had sort of described is the traditional way that we read manuscripts that try to find epidemiological links and risk factors for diseases. So, what exactly is bidirectional Mendelian randomization, and how can that be used as a better or different tool in trying to answer this exact same question?
So if there is something that's a risk factor, in this case, we're thinking about kidney stones, and if there are genetic risks involved with your developing kidney stones, and we can identify those and whatever that risk factor might be, that people will inherit those genes more or less in a random way, is the thought of that's why it's called Mendelian randomization, that you will inherit whatever this risk factor is for kidney stones, and it's a chance event when you're born, and then you live through your life, and you may or may not have what's been clinically diagnosed as kidney stones, but you have this underlying genetic risk factor. So I think that's one of the key things that underlies this Mendelian randomization. And then with these large data sets, then if you can identify the SNPs, the variability in the genome that's associated with kidney stones, and then that's your tool to then look at these other databases and see who has the genes that are associated with kidney stone risk and who doesn't, and then you can start looking at various other outcomes that may be associated with kidney stones or not. I think that's kind of the key underlying factor. There's some other assumptions to this, that number one, whatever genes you're looking at, and it's called an instrumental variable when you identify these variabilities in various genes that might be associated with kidney stones. So you want to understand that whatever you're identifying seems to make sense from what's known about the biology of things, and then also that it's probably not also going to be a genetic risk factor for the outcome you're studying, in this case chronic kidney disease. So those are some of the underlying assumptions when you do this. In these large data sets now, the power of this, number one, is we have hundreds of thousands, if not millions of people to study. So the power becomes quite big to do these kind of studies when we have both the clinical outcomes as well as these genotype data.
And I'm looking at the methodology, and y'all use two cohorts for the Mendelian randomization part. And then you also couple that with an observational study at Mayo Clinic, I guess, as a way to validate the results. Is that why that's done?
Yeah, well, a couple of reasons. So typically you do want to do a study when in two large cohorts. So you either have to divide a cohort into two to do your discovery work and then your validation work in the other half, or it's generally better if you have two sort of independent cohorts. So in this case, we were using the UK biobank, and then this FinGen biobank as well. So they are two, and a lot of people have done that because they are both European cohorts and the populations pair up pretty well that kind of way. So those are the two main ones that we did with the Mendelian randomization. The Mayo Clinic database, we looked at that because that's a much smaller number. So it's about 1,000 individuals, but it's a cohort of kidney stone formers and matched controls, and we had urinary data on them for kidney stone things like urinary calcium excretion. So that was really the main reason for using that. Typically, these other like UK Biobank, the clinical data that might be available is what's been ordered. It's available perhaps in electronic medical records or has been measured in some subset in a study. So they've done things like proteomics on a number of people in the UK Biobank, but getting these kind of urinary supersaturation numbers is not something that's available on any of these other sort of external cohorts at this point in time. So we used the Mayo Clinic Biobank to look at that very specific question when we were trying to sort of dig down into mechanism, perhaps, of why we were not seeing that we were seeing actually that CKD was protective against kidney stones.
Okay, now let's move to what you actually did in the first part of the study with the Mendelian randomization. So you have these two biobanks. One is FinGen and one is the UK Biobank.
Correct. Yep.
And tell us exactly what you did in the first step of this study.
In general, you need to be able to identify kidney stones, if we're going to do this kind of study. So there are reasonable coding codes for kidney stones. So that's going to be how you identify your cases versus controls in these cohorts. And then initially, just to reproduce the associations just with the diagnoses of things like what is like to compare the kidney stone formers as far as how much diabetes they have, hypertension, obesity, those sorts of things. And so that all, I would say, was similar to what we've seen before, that things like diabetes is associated with kidney stones or obesity is associated with kidney stones. So do that kind of initial analysis and then use the genotyping data in both of these cohorts. And we start out with UK Biobank and then look to do a genome-wide association study with kidney stones versus the SNPs that are in the genotyping data. And then the most highly associated SNPs are then what we use to develop this, what we call instrumental variable, that the thing that's sort of a surrogate for kidney stones. And then try to show, does the people that have these genotype risks for kidney stones, do they have more chronic kidney disease or not? And then reproduce that in the FinGen database. So take those SNPs we've identified in UK Biobank and then go into the FinGen database. And so that's where we saw that there really was ultimately no association with chronic kidney disease and prior this genetic risk for kidney stones. And then basically did that all in reverse. So that's why it was called bidirectional. So do the same exercise starting in FinGen and then reproducing that in UK Biobank. So that's kind of shown in one of the tables. It's sort of parallel going one way versus the other way.
Now I'm looking at a figure 3, and you have, is that a Manhattan plot? That's where you look at the entire genome and look at if there are any SNPs that show a correlation. Is that what that is?
The part that looks like a Manhattan plot
Mm-hmm.
is showing kidney stones and CKD, and it's the two. Panel A is UK Biobank and panel B is FinGen. So it's kind of showing the genes that were basically, or at least the areas of the genome that are associated with both of those things. CKD is kind of going down, and kidney stones is going up.
It looks like there's a few that are very similar. Is that true or?
It is very true. So some of these things would be likely, well, they would be if you could drill down and you could actually see it there. But things like uromodulin is associating, I believe, is one of those peaks. So there are some things that are probably very well known, which is not unexpected because people have done GWAS looking at both kidney stones and chronic kidney disease. So a lot of those peaks on those Manhattan plots are reproducing things that other people have shown.
Now, is this actually trying to find genes that have association between both, or is it just using the genetic variability to randomize participants so that you can look at all these clinical associations?
For what we were doing here, it was mostly to really get those instrument variables from the genetic data to then do the subsequent analysis. But certainly you can start digging into the genes you find and use those in other ways as well. I think a lot of that's, been done for these two diseases,
Hmm.
but certainly this would potentially be a validation of that sort of work.
Okay, now let's move on to the results. And what did you find the main findings for your study?
I think the main finding was that once we did all this and controlled for things as best you could, that really we did not see a signal for kidney stones as a risk factor for chronic kidney disease in these studies. So I think that's the main take home message. But on the other hand, when you look at chronic kidney disease and then your subsequent risk of kidney stones, that actually was protective. This is something I would say, I don't know if it's been well appreciated, but I would say clinically makes a lot of sense to me. And we've done work before looking at urinary calcium excretion and GFR. And basically, when you get below a GFR of probably 45 or so, your urinary calcium excretion starts to go down. And that's basically what we're thinking is probably the mechanism here. The vast majority of kidney stones, 80% are going to be calcium kidney stones. And if your urinary calcium excretion is going down with chronic kidney disease, it seems likely that on at least a big picture viewpoint that your risk of stones is going to go down as well.
As we mentioned when we first talked about the background of this paper, and then when you got that result, did you first think, did we mess the data up? Is this true?
Well, not no, not really. I mean, I would say though that especially the Association of Kidney Stones, Chronic Kidney Disease, we kept looking at this and sort of making sure we were controlling for things we best we could and made sure the math was good. And, it's with this sort of thing, you don't just do this in an afternoon. It's many months of work and then kind of going around and being as careful as you can. So in that sense, yes. But I guess in the end, I wasn't surprised by the result, but we just wanted to make sure it was as rigorous as it could be.
You mentioned in the Mayo Clinic cohort, you had a lot of parameters that you could really drill down. And so you show some of those in figure 6. Can you go through some of those?
I think the main one here is it's breaking down people with CKD versus not and looking at the various key parameters. So I think the big one would be calcium excretion. So that's somewhat lower in the CKD population. So 156 in controls, 129 in the CKD. And then just looking at calcium concentration rather than the total excretion per day, that was similarly lower. And that might actually, it's actually proportionately a little lower than just a total excretion. And that's probably because you can't concentrate your urine as well when you have CKD, so probably have slightly more volume as well. And then the supersaturation that's calculated by the Equal program was lower in the CKD group, and then the magnesium also was actually slightly higher, which is interesting, probably not as relevant. And then oxalate also not really terribly different. So we really think that the big driver here is going to be calcium, which I think is well known that calcium
Mhm.
metabolism gets abnormal when you have CKD.
What are some of the challenges interpreting this Mendelian randomization study? What are the pitfalls that?
I think it's important if you can get which we did here, you have to do extra approvals often for these cohorts, but to have the individual level data rather than the summary data, which is usually easier to get the summary data, but actually have the rich data that for the hundreds of thousands of people actually have all those SNPs. That becomes computationally challenging. So doing these analyses, it can take a while just because it takes a lot of computer power to do that when you have all that data. And then I think making sure that things have been validated in multiple cohorts, and it can take a while just to identify what data is out there, what cohort you can study, and then getting the necessary approvals and IRBs and things like that to actually get the data. So on the one sense, it's very feasible to do this, but on the other hand, it's a fair amount of work to do it rigorously. So I think those are some things I would look at.
What's your take-home message for a clinician who's taking care of patients now that we're finding more information about the association between these two?
I think only that kidney stones probably is not and I would say just in general, the generic kidney stone former that you see in clinic with calcium oxalate kidney stones probably doesn't have a higher CKD risk just because of the kidney stones. But we also know that these people have all these other comorbidities like diabetes and hypertension. So those things need to be managed still as well. So I think there have been a lot of speculation that things like crystals and response to crystals in the kidney and fibrosis just from the kidney stones themselves. I think that's probably not going on in most of our regular stone formers. How that would or wouldn't change your management, I'm not sure. Because in the end, we still want to prevent the kidney stones. So I think it's probably more relevant maybe for biology and for public health considerations than patient level things that someone you might see in the clinic.
Is this question answered, or do we have to do more work to confirm this, and how would we do that?
I don't know when you say answered. I think that when I've had these discussions with Andrew Rule here, I think one of the things that we can't do in this sort of data set is recurrence. So this is taking all stone formers and it's kind of averaging your one-time stone former and your 20-time stone former.
Mhm.
And there could well be that if you have somebody that's had many kidney stones through their life and lots of events related to that, that's still maybe a risk factor for chronic kidney disease. So I think that's something that if you had the right kind of data set, I think that would still be an important sort of study to do.
That's a good point. This sort of takes all the vast phenotype of kidney stones and lumps them in as one,
Yeah,
which could be an issue. So thanks for pointing that out. Well, congratulations on your study in JASN. We appreciate your time, and have a great rest of your day.
great. Thanks so much. I enjoyed it.
The next paper we'll discuss in this episode is from Kidney 360, and the title is Pharmacotherapy and Stone Mineral Subtype Influence Long-Term Recurrence Rates in Calcium Stone Formers. I'm very excited to be joined by Dr. Rupam Ruchi from the University of Florida. Welcome to the ASN Kidney Translation Podcast.
Thank you so much, Dr. Sparks. It's a privilege to be here today.
First off, why don't you tell us a little about the background and also the unique aspects of this cohort? What kind of questions that you're trying to ask with the cohort?
We know that kidney stone is a highly prevalent disease, and 1 in 10 Americans are affected by it, which, if you come to think of it, each one of us know at least one individual in our social work circles who are being affected by kidney stones. It's also a highly recurrent disease, and in addition to the surgical morbidity, mortality, it also affects a patient's quality of life in more ways than one. So most of the stones are calcium-containing stones, and in light of all these recurrence and medical morbidity, surgical morbidity, we wanted to look at the factors that will influence the long-term recurrence of kidney stone formers, especially the calcium-containing kidney stones. And the 10-year was really important to us because we know that the stones really are a long-term disease. They don't happen overnight, and the risk factors would have been present for a long time before they're even evident clinically.
Yeah, that makes it very challenging to study in randomized controlled trials because doing something with the 10-year endpoint is very, very expensive.
Yeah.
Curious about your cohort. Were these data entered into a registry, or was this something that you extracted from the medical record?
It is a surgical database that we have maintained since 2010, since the inception of our EMR. So all patients who had kidney stones and had a procedure at University of Florida, they were entered into the surgical database manually. And we had the medical record number, so we had the ability to go back into their records and review the chart.
You mentioned in the paper that there's a multidisciplinary team approach that really started around 2015, which is maybe 4 or 5 years after starting this data set. Can you describe how the patients were followed in the first 4 years, and then after the 2015 mark, what changed?
I think originally when the patients were seen by urology, they were referred to nephrologists. But in the multidisciplinary model, the special thing is that the urologist and the nephrologist both see the patients together, and so the follow up is in real time, and there is ability to have a real time discussion between the two physicians of different teams to be able to comprehensively manage the kidney stone. Also, as a part of this model, the scenario when the patients come in the morning, they get their labs in the morning, then they get their imaging, and then they are roomed. And they are seen by a urology resident and the urology attending and the nephrology fellow and the nephrology attending. And they all come together and with a comprehensive plan for the patient. This comprehensive model is very unique, and that started in 2015. I think before that, there was follow up with nephrology, but it was like a conventional model where the urology will see the patient, refer to nephrology, but whether that nephrology referral happens or not happen, it was not really consistent.
Great. Now let's talk about the patient cohort. Why don't you run us through, what patients were included and which ones were excluded in your study?
So we wanted to look at pure metabolic calcium stone formers. That means we excluded patients with uric acid stones, true white stones, cysteine stones. But also we excluded patients who had treatable cause of calcium stone formation, for example, primary hyperparathyroidism or sarcoidosis or gastric bypass. So these are about all adult patients who had a stone event which was treated surgically. So they were already at higher risk of recurrence based on prior studies that show that patients who have had stones before are at highest risk of recurrence. And these patients were enrolled who entered our database in between 2010 to 2012. And we only enrolled patients who had, of course, the calcium oxalate, calcium phosphate stones, but they had at least 10 to 12 years of follow-up in our data set. So we were able to include 149 patients with such inclusion criteria. It was tough. It was strict because, we have a record of almost 1,200 patients in our database. So out of that, we were only able to find 149.
But the important part is that every single one of these patients had at least 10 years of follow up. Is that correct?
Yes, at least 10 years of follow-up. And
So
that's
that's
the
pretty
most.
impressive to get that many,
Yes, I agree.
because people move, they go away. So that's impressive. So, how many of those patients were included in the medical management side, and how many in the non medical management side?
So patients on medical therapy, we had 46 patients out of 149. So almost 31% of patients were on medical therapy and the rest were on non-medical therapy.
Well, that right there, we should just pause and say, wow, like
Yeah.
that for the model you described,
Yes.
and that's what you achieved. Can you talk a little bit about that? Is that something that's been seen before? Is that surprising?
Yeah, 31% patients on medical therapy. And this is a group we are talking about who are already at high risk of kidney stone formation. This is consistent with other studies. The rate of medical therapy in a lot of patients with stones is low. I think the patients, when they are in the community, when they have a kidney stone, they are going to their primary care doctors or neurologist, and I think their training for medical prevention of kidney stones can be improved. They're started on medical therapy at the outset when they see the community physicians. And like I was mentioning below before, the most of the referrals to nephrology are coming from urology, not the primary care doctors. So I think the problem is that we need to educate more doctors in medical prevention of kidney stone disease.
I guess what worries me though is that this is probably the best model that you can get, the multidisciplinary approach. How low is the uptake, you think, in a community practice that does the traditional way?
I can not speak about the community, but a lot of my referrals come from UF urology. So people, who know that the multi-T clinic is there, or word of mouth referral. We had a patient, they had good outcomes. They tell patients in their community or through social media that, UF has this model, and then they come to us. The rate or referral from primary cares and community urologists is not much.
31% of patients in the
Yeah.
best model you can get. It's
Yeah,
kind of a sobering statistic.
exactly.
Okay, well, that means we have a lot of work to do. Let's talk about the baseline urinary parameters for your cohort. Were there any differences or anything to point out in the patients that received medical therapy versus those that did not?
The only difference we saw was among patients on medical therapy, they had lower urinary citrate as compared to patients who were not on medical therapy. And then their urine pH was also higher, like more than 6, in patients on medical therapy versus not on those. Overall, the whole cohort where we did the 24-hour urine study, they had low urine volume and high urine sodium, but they were not statistically different between those two groups.
Yeah, looking at the data, it looks like it's quite lower, the citrate excretion 24 hours.
Yeah.
Do you think that
Right.
create a scenario where the physician was more adamant to the patient to take medical therapy, given that citrate's one of the more commonly prescribed interventions?
I completely agree.
Well, that's very interesting. Okay, so we got the 24-hour, and I guess the other thing to point out, is, as you just rightfully mentioned, is that the urine volumes were about 1.7 liters in both groups. What is your goal for urine volume for a patient who is a stone former?
At least 2 liters. And then, given insensible losses, I tell them to drink at least 2.5 liters of fluids to achieve a volume of 2 liters at least.
So we already have a scenario where, we talk about medications, but is that a parameter that you used in medical therapy, was increasing your urine volume? Is that something that was tracked and put into the medical therapy group, or is that not included?
All patients were advised about, lifestyle modification, low sodium diet, drinking more fluids, restricting animal protein. But this was not tracked, and it was not tracked whether it was different between the medical therapy group and non-medical therapy group.
Okay, so let's move on to what the patients were taking. This is in table 3 of the 46 individuals who were taking medical therapy over that 10-year duration. What were the most commonly prescribed medications?
The most commonly prescribed medications were thiazides and potassium citrate. And less commonly, in 10% of the patients, we saw that allopurinol was prescribed. The thiazides were also, I think, when you look at the baseline characteristics of the group, they were only different in the medical therapy group had more patients with hypertension than in the non-medical therapy group. And it is quite possible, because thiazides are the first line therapy for hypertension, it is possible that they were on thiazides primarily to treat hypertension than kidney stone disease. But yes, I think 20% patients were on combination therapy.
You note that you'd only use hydrochlorothiazide in this cohort. Were there individuals on chlorthalidone, or is it just a
You,
regional difference that people typically use hydrochlorothiazide in this cohort?
we looked at all thiazide and thiazide-like diuretics, and we only found patients who were on
That's
hydrochlorothiazide.
very interesting. Maybe, like, United States, probably during that era that was likely true, but it seems like now there's been a resurgence of chlorthalidone. Um,
Yes, I have been using more chlorthalidone and indapamide as well recently.
yeah. And a small comment, can you make a comment about the allopurinol?
There have been studies which have shown that there is an association between high urine uric acid and calcium oxalate stones. And the basic physiological basis is not entirely known, but I think it is, they stipulate one of the reasons to be because of the uric acid kind of nucleates and the calcium oxalate grows on it. And in those studies, there has been reportedly an association between giving allopurinol and outcomes in calcium oxalate kidney stones. And I don't know if these patients were started on allopurinol because they were on allopurinol because of high uric acid, gout history, or whatever, or they were specifically started on that when their urine uric acid was high.
Okay, let's move on to what you showed in table 4 about medical therapy.
So table 4 shows the association between medical therapy and the stone event, and it's a multivariate analysis, and we are looking at two factors, one of the medical therapy and then also the stone, calcium phosphate mineral content content that are significantly different between the group which was high stone recurrence. That table showed that the patients on medical therapy have a 54% lower risk of, at least associated with a 54% lower risk of kidney stone recurrence than patients who are not on medical therapy. And the calcium phosphate stone content, at least having 51% or more of calcium phosphate stone content, those patients were associated with 94% higher risk of kidney stone recurrence versus those who had more calcium oxalate in their stones.
So over a 10-year period, the medical therapy group had a very marked reduction in risk of recurrent stones.
Right,
And also that the presence of calcium phosphate was a marker of an increased risk of recurrent stones.
right.
But as far as the baseline characteristics of the urine, like hypocitraturia, hypercalciuria, you didn't really find any association there.
No, the only association was urine pH more than 6. And that was also an association that was associated with patients who have higher stone recurrence versus those who did not recur. And this is in line with the calcium phosphate content of those recurrent stone formers.
Yeah, can you explain that exactly? Why is having a higher pH would be a risk? Is it that you can modulate the lower pH to make it higher? What is what is the reason for that?
I think these are pure metabolic stone formers, the calcium phosphate ones. Number of them probably have incomplete distal RTA, which has not been diagnosed. And this is a very difficult entity to diagnose because for conclusive diagnosis, these patients have normal bicarb, and that's the problem.
It's
So
hard to
serum
figure
bicarb
out.
is hard to figure out, and then you would have to do an acid load test
No
challenge
one does
to
that.
see if they're in a study. They tried to do that, and 50% patients, they have to take ammonium chloride, and 50% patients threw up that ammonium
Oh,
chloride. It is such a
that's not.
non-palatable
Yeah,
situation.
let's not have that. Yeah.
So we would rely on, urine pH, more than 6 specifically, and then hypocitrate urea in a patient with predominantly calcium phosphate stone formation. Even though they have a normal serum bicarb, they may or may not have hypercalciuria or high urine calcium. But it is kind of indicative that they may have some tubular dysfunction in acid secretion.
The elephant in the room is the no stone trial, which you rightfully discussed in your discussion. Obviously, it also used hydrochlorothiazide. Can you discuss a little bit about that study and how it jives with your study in which you show that medical therapy seems to work? And the second most commonly prescribed medical therapy was hydrochlorothiazide. So, why do we see in no stone no difference in recurrence, but yet you're showing in this study that there is? Of course, you also have other medical therapies you use, but any thoughts on that?
Great question. I think No Stone study was a very well conducted study. They were also very specific in inclusion criteria for their patient. They also started with a patient cohort who had stone events before, so they were at higher risk for stone formation. They also had patients excluded with, infection stones, uric acid stones, and concentrated purely on metabolic stones. They also excluded patients with primary hyperparathyroidism, all these secondary causes. So I think the cohort selection was pretty much similar as our study. The only thing different, like you said, was they were only testing hydrochlorothiazide and they were not, or thiazide, and not testing the use of other medications for stones, such as potassium citrate or citrate therapy. And I think this is important because a number of those patients in the No Stone study had low urinary citrate, but they were not offered the citrate therapy. And our study looks at the medical therapy in general, not just at thiazides. And also, I think the follow-up period, the follow-up duration of No Stone was 2.9 years. And as we have shown in this study, we were looking at the Cox proportional hazard models, and we looked at the separation of the curves between the medical therapy group and non-medical therapy group in terms of stone recurrence. And that doesn't happen until 60 months of therapy. So 60 months, like 5 years. And I think this is what is important because stone formation, we have to understand, is a long-term disease. It's not a one-time event and it doesn't happen overnight. So I think even for the beneficial effect of medical therapy to be seen, it takes time. And that is where I really think that if this study was longer, we would have seen some beneficial effect.
That's a great point. And I'm looking at the Kaplan-Meier curve in figure 2, and I think it really solidifies what you just said is that, wow, 5 years in, and if you were to publish this study at 5 years data, which is quite possible you could have done that, right? You picked
Yeah.
10, but if you would have picked, your group would have picked 2,
Yes,
it would have looked like there's no benefit at all.
absolutely.
And then you go out to 10 years and you see a pretty marked reduction. So I'm looking at this, and about a little more than half of the patients have stone recurrence during 10 years. There are only
Yes.
about 25% in the medical therapy group. So that's pretty good.
Yeah.
Yeah. Okay. So that means, don't completely throw out the thiazide diuretics. Now, I've been seeing recently on board examination questions that one of the subgroups that we should still highly consider thiazides is those that have hypercalciuria. Can you comment on that?
The hypercalciuria is difficult to define because, as we know now, the urine calcium and the risk for kidney stones, especially calcium kidney stones, there's not like a cutoff where you say, less than 250 milligram of calcium, you don't have risk for calcium stones, and higher than 250, you have. It is a continuum, and the risk rises with the degree of calcium in the urine. So I think that we should not look at just one number in the urine and say if the urine calcium is less than 200, we should not treat those patients with thiazides. If the patients are having recurrent kidney stones and they can tolerate thiazides, I still advocate for thiazide diuretics in those scenarios, especially, additionally with the low sodium diet and not taking the calcium supplements, Tums, and all of those things are of course, valid. And in patients with calcium phosphate stones, this is especially true because, like we saw, these patients are at particularly high risk of stone recurrence, and their urine pH is often high. So, treating them with potassium citrate is challenging. You really need close monitoring of supersaturations of calcium phosphate, etc. But in these patients, I really try hard to bring the urine calcium to at least 2 digits.
So, in particular, if you have a patient with the majority calcium phosphate stone represents, and as you saw in the data, a quite high recurrence rate, up to 60%. Those are patients that, using a thiazide diuretic could be very beneficial. Okay, great. Fantastic study, very provocative. And, I think it comes at a great time because I think oftentimes a randomized controlled trial like No Stone, published in a very prominent journal, sometimes can take our eyes off things that we're doing, especially with thiazides. And I think your study helps to help think, okay, maybe there were some issues, the long-term duration. I think we didn't talk about it, but the longer acting nature of a chlorothalidone versus hydrochlorothiazide. And so it's still a very valuable tool to use for our patients.
I agree. I think in No Stone study as well, the hydrochlorothiazide was used in a once daily dosing. And I don't, particularly say that in our study it was used in a twice daily dosing. But going forward, I think longer acting thiazides, or thiazide-like diuretics such as chlorothalidone and dapamide, should at least be considered for these patients.
Any last comments that you want to make about your study?
It was a retrospective study, so it has its limitations. And I think one of the comments I want to make is the rate of 24-hour urine study, even though this is such a dedicated group of clinic physicians as well as very motivated group of patients, the rate of 24-hour urine study was particularly low. And it highlights the challenges in patients to get a 24-hour urine study. And then oftentimes we wait for the patients to get a 24-hour urine study to start them on medical therapy. And because the rate of 24-hour urine study is so low, a lot of patients don't get started on medical therapy. And I remember a paper from Dr. Goldfarb a couple of years ago talking about, how a lack of 24-hour urine study should not deter us to start medical therapy. And I think this is a point I would like to make as well. If the patient is unable to do a 24-hour urine study because of any reason, this still, could be started on medical therapy with thiazides and citrate and go from there.
Thank you so much. This is a fantastic study. And also want to just point out the co-authors that did the study. It was a multidisciplinary approach to it with urology and nephrology. And congratulations on a really nice paper. final paper we'll be covering is from CJASN titled Risk Factors in Asymptomatic Kidney Stone Passage in Adults with Recurrent Kidney Stones. We have Dr. Kevin Stritt, who is a postdoctoral fellow at the University of Lausanne in Switzerland. Welcome to the ASN Kidney Translation Podcast. Thanks for joining us today.
I'm Kevin Stritt. I am a chief resident at the Lausanne University Hospital, and I'm happy to participate today on your podcast.
Well, fantastic. Let's first get to No Stone. I remember this very well because it actually was a poster at Kidney Week and turned into a New England Journal of Medicine article. So for all those researchers out there, just having a poster does not mean that you're not going to get your paper in a high impact journal. So tell us, what is No Stone?
The No Stone study was a study to show the efficacy of hydrochlorothiazide in the recurrence of stone. And in that study, we try different doses of hydrochlorothiazide and placebo during a follow-up of 3 years, and we didn't see any change in the recurrence rate of kidney stone in that follow-up time.
So that was a blockbuster when it came out. How long did that study go?
The study lasts from 2017 till 2019 through 12 centers throughout Switzerland, and it was 416 patients included in that study.
What was the median number of years that patients were followed in that study?
That was 35 months, the median follow-up time. And what was important in that study, we had a CT scan at the beginning and at the end of the follow-up. So we had the two images and we show all the images to observe the stone load at the beginning and at the end of the follow-up.
So that's every patient had 2 CT scans before and after. And my guess is many had CT scans in the intervening time, but that was probably not protocolized. It was just if they had a stone. Is that right?
It's right, yeah. And we had a strong follow-up from all the symptomatic spontaneous stone and all the kidney stone intervention to remove the stone.
This is a analysis of the no stone protocol because you had so many patients, you had the longitudinal assessment of these individuals. What were the questions you were trying to answer with this current study in CJASN?
It was to show the natural history of asymptomatic stone and to show the frequency of asymptomatic spontaneous stone passage in that study. And we have the data from the 2 CT scan at the beginning and at the end of the follow-up, and all documented symptomatic spontaneous stone passage and kidney stone intervention. And with that, we have found the asymptomatic spontaneous stone passage for the first time, I think. So we have analyzed all the images from the CT scan and the stone load at the beginning and at the end. And then we have shown all the documented spontaneous stone passage and all the surgical stone removal. And with that, we could show the asymptomatic stone passage, the frequency in our population.
So since you had the CT scans before and after, you could surmise that some of those stones passed asymptomatically?
That was the analysis in that study. Yeah.
How many patients actually had symptomatic stones during the time in which they were in the no stone trial?
That was 442 stone event, and that was in 209 patients. So 55% of the patient have a stone event in the 3 years follow-up.
And how many asymptomatic spontaneous stone passages occurred?
That was 158. So that is 36% of the stone event was an asymptomatic spontaneous stone passage.
So one thing I saw that was surprising is that there were 15% of the stones need to be surgically removed. Is that higher or lower than what has been reported in the literature?
It's difficult, but we have no report the asymptomatic spontaneous stone passage before that. But as we see actually in our clinic, that's a little bit more than 15% surgical stone removal.
So in your clinic, it's more, but in this study, it's a little bit less. Is that because potentially the patients enrolled in no stone might be a little bit less aggressive in the number and amount of stones they have?
And that's a population who have a recurrence stone event with calcium-containing kidney stone. So that was already a risk population from stone formation.
One thing that you found that was very interesting was the size of the stones. Can you describe, was there a difference in the size of the stones that were passed between the asymptomatic?
We don't see a significant difference in the size of the stone. That was not statistically significant.
How did you know the size of the asymptomatic stones?
We don't have measured the size of the stone after symptomatic spontaneous stone passage, but we have seen on the CT scan which stone or the which one had passed, and with that we have showed the size of the stone.
So if you look at the CT scan before, you could see the size, and then the one that you did after the study was over, if it was gone, then you would assume that one passed.
That was we have do that to show the size of the stone. Yeah.
Now, the last thing is to look at, how many stones were passed, and you first have a CT scan to see the burden of stones. Was there an association between how many stones passed and the CT scan done at the beginning of the study?
So we see if you have more stones at the beginning, so we see then more spontaneous stone passage, what can be normal. So if you have more stone, you have more stone that pass spontaneously over the time.
Now, this study was a post hoc analysis, and did you actually look at differences between the hydrochlorothiazide versus the placebo in this study, or is this just purely looking at all the stones, regardless of where they were in the study groups?
We have showed the study groups, and we don't see any difference between the study groups and the different doses of the hydrochlorothiazide in the spontaneous stone passage.
And that was analysis from the original publication, not this one. Is that correct?
Yes.
Is there anything that was surprising in your analyses of the no stone trial in this publication?
For me, was the number of asymptomatic spontaneous stone passage. That was a third of the stone event. That was a lot of stones, and I think that is something new. Yeah, that we have that information.
So basically, there's a lot of passage of stones we just don't know about. And it's the tip of the iceberg when you see the symptomatic stone. There's a lot going on. What is the take home message for nephrologists or urologists that are taking care of patients with kidney stones after reading this study?
So we have a high number of patients have spontaneous stone passage without symptoms, and the total number of stone at randomization was associated with both symptomatic and asymptomatic spontaneous stone passage. And I think this result should encourage the urologist or the nephrologist to counsel patients regarding the possibility of an active surveillance strategy when smaller kidney stones are present, while a number or the high number of that kidney stones can pass without symptoms.
In regards to no stone, trying to think about the treatment of individuals with kidney stones, obviously you showed, at least in this time period, hydrochlorothiazide really didn't make a difference at all three doses. What do you think about other pharmacologic interventions, increasing urine output, citrate therapy, diminishing oxalate, and then the last would be, what about chlorthalidone? So can you sort of describe where are we at with the medical management of kidney stones post no stone?
There is some group or nephrologists who are no more aggressive with hydrochlorothiazide, or they choose the population with hypercalciuria to give that medication.
Right. So basically, finding patients that have hypercalciuria at baseline might be a better population to use it in rather than just all stone formers. There is another paper on this podcast that we're going to talk about in Kidney 360 that looks at stones over a decade, and medical management seemed to make a difference, but it takes about 10 years. Do you think that the no stone trial was too short to really show benefit of medical management with thiazide diuretics?
That's the critic of the study, and that won't do a follow-up after 5 years. So we want to do a second part of the no stone study to show the stone recurrence after 5 years, and we are actually trying to begin that study. I think we need more than 3 years to show an effect of the medication.
Thank you so much. Congratulations to you and your group for this wonderful addition to the literature. And we will see everyone next time on the ASN Kidney Translation Podcast, and have a great day.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.